company in Zimbabwe, and one of the products that we have registered this year is Cannabinoida, which is a cannabis-based medicine, the first to be registered by the Medicines Control Authority of Zimbabwe. In Zimbabwe. So that's some exciting stuff there that is happening in Zimbabwe. And so I'm just going to talk briefly about the endocannabinoid system, and then we can move to questions later. Yep. So may I have the slides, Jackie? Is that on? Right. So I think the first thing that I'd like to just talk about, which I find really interesting, is the historical perspective in terms of cannabis use. And Dr. Jackie spoke about how cannabis is a plant that has been used in Africa for such a long time. And it's part of the African indigenous medicine knowledge system for many, many centuries. And obviously, the biggest thing, which is the thing with a lot of our African medicine and indigenous knowledge, is there wasn't a lot of writing about these things. But the earliest recordings of the use of cannabis in medicine in the world go as far back as 4000 BC. And the records are mainly coming out of Asia, Southeast Asia, and also out of Egypt. And in 4000 BC, some records were discovered where cannabis was regarded as amongst the 5 grains in China, and it was actually farmed as a major food crop. In 2737 BC, so that's a long time ago. The earliest record of cannabis as a medicinal drug has been found. At this time, Emperor Shen Nung recognized its treatment properties for over 100 ailments such as gout, rheumatism, and malaria. So there's quite a lot of history in terms of cannabis use. The thing that I find most interesting about when you dig into history in terms of the use of cannabis, particularly in medicine, the most interesting thing is that the indications that are mentioned in the Egyptian papyrus and in the ancient Chinese records, when they talk about the indications of the cannabis, what they were using the cannabis for and to treat what exactly. The really interesting thing is those are actually the very same things that we are, supposedly discovering now in science, and papers are being written about, and clinical trials are being done. The indications have been very consistent right from as far back as 2737 BC. Cannabis was regarded as an effective treatment for pain, inflammatory, as a powerful anti-inflammatory, and for things associated. So this is really interesting because there are very few drugs that we actually have which have such a detailed history dating from that far back and with such consistency, just in terms of indications and what ancient physicians were treating in Egypt is exactly what we're actually treating today with the same medicine. So that's something that I found really interesting and I wanted to share. So just over to the next slide. So if we the next one, cannabis use in medicine. So I'm going to address a couple of questions which usually come up. They come up whenever we're talking about our registered product, but also generally when people talk about cannabis use in medicine. I mean, the major questions are, so is it legal? Will it make me or my patients high? Is it addictive? How does it work? Does it work? Who is it for? How do I prescribe it? And is it accessible? And these are the questions that, consistently come. And I'm going to try and address some of these things. So on the next slide, the first question is it legal? So the answer to that is yes. Well, as far as, Zimbabwe and some of our other countries in the SADC region who have managed to register some medicines, it is legal. The registered medicines are legal, and there are guidelines for registration. Our particular medicine, which is registered with the MCAZ, is under that registration number. So, yes, we do have legally registered cannabis-based medicine world over, which are in use everywhere, including Zimbabwe, in terms of registered medicine. And on the next slide, will it make me high? So this answer was mainly targeting our particular product, which is containing less than 1% THC. And I think this is consistent within our SADC region in terms of our regulatory bodies. So anything which is containing below 1%, for some countries it's 0.4% or less. But no, if something does not contain that level of THC, when it's below 1%, it will not make anyone high. It does not have that capability. And as we talk about the endocannabinoid system, I will get to explain why that is. And then we can understand it from a scientific point of view. Why doesn't it make, the patient high? This is cannabis after all, so we are going to talk about it as we dig into the science. So just moving on to the next slide, which is the question, how does it work? Well, it starts with a little system called the endocannabinoid system. Many of us have heard of some of the systems within our bodies, such as the sympathetic nervous system, which gives us our fight or flight response, or the cardiovascular system. Few people, though, have actually heard of the more recently uncovered endocannabinoid system. So, the endocannabinoid system regulates and controls many of our most critical body functions, such as learning and memory, emotional processing, sleep, temperature control, pain control, inflammatory and immune responses. It also regulates eating. So that's an interesting one. Just on the next slide, the endocannabinoid system is composed of endogenous cannabinoids, cannabinoid receptors, and the enzymes responsible for the synthesis and degradation of the endocannabinoids. So basically, we're saying that everyone is born with an endocannabinoid system. And this system, like any other system in the body, has its endogenous ligands, which are known as the cannabinoids, and it has receptors. These are our cannabinoid receptors. It also has enzymes, which are responsible for the synthesis of these ligands, as well as the metabolism of these ligands, these endocannabinoids. Okay, so everyone has an endocannabinoid system. So the naturally occurring endogenous cannabinoids are 2-arachidonyl glycerol and arachidonyl ethanolamide. And these are the endogenous cannabinoids which are existing in all our bodies at any given time, and as far back as Adam and Eve, depending on what you believe. Right, and on to the next slide. This is just a this is just wrapping up what we're saying. So we have cannabinoid receptors, and the cannabinoid receptors that have so far been identified, which are the dominant and by far major receptors, are the CB1 and CB2 receptors. Okay, so this is important that they've been identified, and this is pretty recent knowledge, because these receptors were actually identified and named just as recently as 2019. So this is very recent. And then we have our endogenous ligands, our endocannabinoids. We talked about those, anandamide and the 2-arachidonyl glycerol. Then we have our anabolic enzymes, diacylglycerol lipase and phospholipase A1. We have our catabolic enzymes, which is fatty acid amide hydrolase and monoglyceride lipase. Okay, so it's important to understand the system if one is to understand how it's working, and also so that we understand that the use of cannabis in medicine is not one of those things that, is being tried. It's actually based on science, and there is a whole system which caters to this. We just haven't really been exploring and learning about it in our schools. So just on to the next slide. I'm going to talk about the CB1 receptors. So CB1 receptors, could I have the next slide, Jackie? Thank you. So CB1 receptors are expressed primarily in the brain and to some extent in peripheral tissues. Within the brain, these sites are not distributed homogeneously. CB1 receptors are most dense in those areas in which cannabinoids are thought to produce many of their characteristic effects. So, for example, cognition, short term memory, that's your cerebral cortex, your hippocampus, motor function and movement, that's your basal ganglia and your cerebellum. So, our CB1 receptors are found primarily in the brain, and a few, very little to some degree in peripheral tissue. So this is important. If one is to understand how CBD medicine is working, one must first understand these receptors, and you'll see how it all ties in as we talk about the other receptor and some of the indications. So onto the CB2 receptors. CB2 receptors. Next slide, please. So CB2 receptors are identified peripherally. So we mainly find these in peripheral tissue. They have been found in the circulating immune cells, the spleen, and on macrophage-derived cells, including your osteocytes, your osteoclasts, and your hepatic Kupffer cells. Unlike the widespread expression of CB1 in the central nervous system, the expression of the CB2 receptors under normal physiological conditions is actually restricted to the brainstem and the hippocampal pyramidal neurons. CB2 expression, however, is induced on the reactive microglia in the CNS following inflammation or injury. So this is actually really important that we get upregulation of CB2 receptors where there is inflammation, because this then speaks to how our cannabidiol CBD is working. And when we talk about how THC works on CB1 receptors, it then makes a lot of sense. So both the CB1 and the CB2 receptors are known as 7-transmembrane. They are G protein coupled receptors, and they share an overall 44% identity. So they have 44% identity there between the CB1 and the CB2 receptors. Right, and on to the next slide. The CB2 receptor, like I mentioned, is primarily expressed only when there is active inflammation. It is devoid of all undesired psychotropic effects or addiction liability. So this is very important because particularly this comes up for those countries where it's still being considered, should we register cannabis? Is it going to be dangerous to society for medicine? CBD-based medicines, which are acting primarily on CB2 receptors, CB2 receptors themselves are devoid of undesired psychotropic effects or addiction liability. So a medicine that is mainly working on these receptors is not going to actually express some of the issues of addiction and the psychotropic effects that are usually associated with cannabis, and which are usually the issue that has been very difficult in terms of registration of cannabis-based medicine on our continent and in other parts of the world. So just on to the next slide. There I've just put a diagram of we've probably, most of us have seen this before, the interaction between a receptor and your ligand, the cannabinoids, the endocannabinoids, where they bind to the CB2 receptor, and this is just action on an immune cell. So this is something that we've all kind of seen, and it's what's happening with the receptors in the endocannabinoid system. So on the next slide, just to show pictorially the distribution of CB1 and CB2 receptors. So the green color is not there is a slight difference in terms of the shades of green. But basically, what we're trying to highlight is the location of CB1 receptors versus the location of CB2 receptors. So if you look on that picture, you see that your CB1 receptors are mainly concentrated there in the CNS, where they are mainly controlling motor activity, thinking, motor coordination, appetite, short-term memory, pain perception, and immune cells. However, your CB2 receptors are mainly expressed peripherally. So you can see those receptors are everywhere in the body, in the peripheral tissue, and they are found in the gut, in kidneys, pancreas, adipose tissue, skeletal muscle, bone, eye, reproductive system, immune system, respiratory tract, skin, central nervous system, cardiovascular system, in the liver. And quite interestingly, CB2 receptors are also found in tumors. So CB2 receptors are expressed and upregulated in tumors. Okay, so on to the next slide. So what is cannabis anyway? I mean, there's a lot of confusion. What is this cannabis and what is it about, the plant? So cannabis is the naturally occurring cannabis family encompasses three major species: the cannabis sativa, cannabis indica, and cannabis ruderalis. The cannabis plant itself contains more than 500 natural compounds, and these include more than 100 cannabinoids. So this is actually important because a lot of people have asked questions like, so how come cannabis is indicated for so many things? Why is it indicated to help with mental health issues, things like anxiety, but at the same time it's an anti-inflammatory? And the answer really lies in the wide range of cannabinoids, many of which have not actually yet been identified by science and named, and especially some of the natural compounds that are in the plant as well. And each of these actually has a different effect in terms of how it binds to the receptor and in terms of what it does in the body. And so the plant itself, because it contains so many different cannabinoids and other compounds which have medicinal value, can be found to do many different things. So it's not magic. It is actually, there is a science behind it. It's the different compounds and the different cannabinoids. And this is significant because as cannabis medicine has been, the fraternity has been growing and there's been a lot more research, there are more molecules coming out where we have had separation, where you have specific cannabinoids and specific terpenes and other natural compounds which are being made into a single medicine, which are being registered for specific issues. And that is really important because it begins to really delve into specificity, which is very important in medicine. So like I said, the full characterization of all the cannabinoids is actually still lacking. Marijuana is composed mainly of the dried buds of cannabis sativa. So what we know as dacha or marijuana or mbanje or whatever you call, there's so many names for it because it's been around for so long and every culture has some name for this plant. The delta 9 tetrahydrocannabinol, delta 9 THC, is the primary psychoactive cannabinoid of marijuana, which acts as an agonist on CB1 receptors. So this is important because we talked about CB1 receptors and how they are located in the CNS and how they give CNS reactions. And so this delta 9 tetrahydrocannabinol, commonly known as THC, this is the primary psychoactive ingredient of marijuana and it acts on the CB1 receptor. Okay. Cannabidiol, commonly known as CBD, is another major component of the cannabis plant, and it acts as a non-competitive negative allosteric modulator of CB1 receptors, and it's an inverse agonist of CB2 receptors. So it's quite a mouthful there with non-competitive negative allosteric modulator. It takes us all back to our biochemistry. Obviously, we know non-competitive, meaning it's not competing for the active site. It's a negative allosteric. It's an allosteric binding to a site other than the active site, and it's modulating CB1 receptors, right? So that's really important. On to the next slide. Just to summarize, because we've talked about a lot of things already. So what we know so far, the endocannabinoid system is one of the systems in the human body. The body synthesizes endocannabinoids, which have many functions in the body. The endocannabinoid system has mainly two receptors, CB1 and CB2. CB1 receptors are mostly found in the brain, where they're responsible for memory, pain perception, and some motor functions. CB2 receptors are found in the periphery, in tissues of the kidney, liver, gut, bone, and eyes. CB2 receptors are also found in tumor tissue, where they regulate cell division and growth. The cannabis plant consists of over 100 cannabinoids, and the main ones of these cannabinoids are THC, or delta 9 tetrahydrocannabinol, and CBD, or cannabidiol. THC is active on CB1 receptors, which are mainly in the CNS, and CBD is active mainly on the CB2 receptors, and it downregulates CB1 receptors. Okay. And it's an inverse agonist of CB2 receptors as well. So this is what we know so far. So on to the next slide. Let's talk about this CBD, cannabidiol. So it is a naturally occurring agonist. So natural occurring means we're getting it from nature. And it's an agonist, an inverse agonist of CB2 receptors. It's also a negative allosteric CB1 modulator, which means it's down-regulating CB1 receptors. Okay. Right, on to the next slide. So that's all about what I have to say about CBD. But what is the World Health Organization saying about CBD, cannabidiol? So the World Health Organization has published a critical review of cannabidiol, and this is available publicly. One can just Google it and download it and have a read. But this is just to summarize some of the things that have been said in this critical review of CBD by the World Health Organization. And they have found that CBD has low toxicity, it affects growth of tumor cells, it has a pro-apoptotic effect in lymphocytes, it has no effect on embryonic development, it has no effect on a wide range of physiological and biochemical parameters, or any significant effects on animal behavior, unless in extremely high doses, in excess of 150 milligrams per kilogram, and when given intravenously as an acute dose, or in excess of 30 milligrams per kilogram orally daily for 90 days in monkeys. That's when they saw some slight alteration in animal behavior. So basically, it doesn't really have an effect at normal doses. There's evidence of immune suppression at high concentrations, but immune stimulation may occur at lower concentrations. There is potential for CBD to be associated with drug interactions through inhibition of some cytochrome P450 enzymes. So it's a P450 inhibitor. We know some drugs that behave similarly. And adverse reactions in humans. The World Health Organization has concluded that CBD does not produce the effects that are typically seen with cannabinoids such as THC. It is well tolerated and has a very good safety profile. So this is the review of the World Health Organization for cannabidiol. Okay, so this is just this is going back to our pharmaceutical chemistry, or chemistry in general. And this is the molecule of cannabidiol. Okay. Just on the next slide. So the CBD chemical activity is mainly due to the location and surroundings of the hydroxyl groups in the phenolic ring at the C1 and C5 positions. Maybe let's go back to the molecule so that people can relate with the molecule. If we can go back to the last slide. Okay, so the CBD chemical activity we said is mainly due to the location and surroundings of the hydroxyl groups in the phenolic ring at C1 and C5 positions. So you can see those in the molecule. And the methyl group at the C1 position of the cyclohexane ring A, and the pentyl chain at the C3 of the phenolic ring. The open CBD ring in the C4 position is actually inactive, so that doesn't bind to any of the sites on the receptors. Due to the hydroxyl groups, that's the C1 and C5 in the B ring, CBD can also bind to amino acids such as threonine, tyrosine, glutamic acid, or glutamine by means of a hydrogen bond. So that's pretty straightforward. CBD has potential antioxidant properties because its free cationic radicals exhibit several resonance structures in which unpaired electrons are distributed mainly on ether and alkyl moieties as well as on the benzene ring. So we can see those moieties, the ether and the alkyl moieties there on the molecule. Okay, so moving on to the next slide. Functions of cannabidiol, the one after this one. Functions of cannabidiol, right? So cannabidiol has been found to be a very powerful antioxidant. It's been shown to affect the redox balance by modifying the level and activity of both oxidants and antioxidants. CBD interacts free radical chain reactions, capturing free radicals or transforming them into less active forms. CBD reduces oxidative conditions by preventing the formation of superoxide radicals, which are mainly generated by the xanthine oxidase and the NADPH oxidase, NOx1 and NO. CBD also promotes the natural antioxidant activity in the body. Okay, so this is quite significant. On the next slide, there's just a summary in diagrammatic form of the antioxidant effects of CBD for those who will go through the slides later. So this just summarizes what it's doing and how it's doing it. So why are the antioxidant properties of CBD important? On the next slide, why are antioxidant properties of CBD important? Free radicals damage and contribute to the etiology of many chronic health problems. So we know this. We've known this, for a while in science, that free radicals are very damaging. They contribute to many of chronic health problems that we see, and such as, for example, your cardiovascular and inflammatory disease, your cataracts, cancers, are all due to this. So antioxidants prevent free radical-induced tissue damage by preventing the formation of radicals, scavenging them, or by promoting their decomposition. So CBD in particular does all three. And this is really important because it's a really powerful antioxidant. And then moving on to the next slide, the anti-inflammatory properties of CBD. Where are those derived? So CB2 activation leads to a decrease in TNF alpha levels, which reduces oxidative stress and inflammation. So this is important. CB2 receptors are upregulated during inflammatory conditions. An inverse agonist can downregulate these receptors, hence cutting off inflammatory response. Clinical studies have actually confirmed that CBD reduces the levels of pro-inflammatory cytokines. It also inhibits T cell proliferation. This is at high doses, and induces T cell apoptosis and reduces migration and adhesion of immune cells. But this is mostly at very high levels, as was mentioned in the WHO study. But this shows that your CBD is quite active in terms of being an anti-inflammatory, and it does have quite powerful anti-inflammatory effects. what is quite significant is that if you look at the anti-inflammatory mechanism of action, unlike a lot of the anti-inflammatories that we know, um, it's mostly based on reducing the inflammation, but without the analgesic effect that we commonly see with some of our NSAIDs. And so this is quite important because in clinical use, you get a lot of patients who report that after using the CBD medicine, they gradually begin to see that the pain is going away as the inflammation is also going away, and then even after they've stopped, it takes a while for the inflammation to get back and for them to get back to the pain that they had before, and that is because of how powerful the anti-inflammatory effect is, but without necessarily having that analgesic effect. So some patients will report that they don't necessarily immediately feel that analgesic effect, but the anti-inflammatory response is happening over a couple of days, and eventually they actually don't feel the pain anymore and the inflammation is gone and they're doing a lot better. So this ties in with what we're seeing in terms of the clinical response versus what the science is saying, and there's a relationship there. Just on to the next slide. Anti-tumor properties of CBD. So I've just put in these for those who will go through the slide later. But let's talk about the pharmacological basis for application of cannabidiol in cancer chemotherapy on the next slide. And so there's a paper which I have attached there, a publication. On the next slide, the pharmacological basis for application of cannabidiol in cancer chemotherapy. Could I have the next slide?
It's not moving at the moment. Just hang on a sec.
Moving. Okay.
It asked me to accept cookies, and then I accepted them.
Okay.
Pride, any suggestions?
Are you failing to move to the next slide?
Yeah. It should just move on the click, but it asked me if I'd accept cookies, and I said yes. And then it's failing to move.
Okay.
Can you share again?
Carry on, Pride.
Stop sharing and then reshare again.
So stop sharing.
And then share again, yes.
Okay. Stop sharing. The screen.
Okay, so yeah, back. Okay, yes, there we are. Forward. Next slide. Next one. Yep, excellent. Okay, so we're back. So this is just a publication on Science Direct. I've put the link there for those who will access the slides to go through them later. And so basically this speaks about the CB. It says basically, just to summarize the paper. Sorry, back to the last slide. What's happened there? It's jumped. Okay, previous slide. And the one before that. Yeah, there we are. So the available scientific preclinical data show that CBD may be applied in cancer therapy. Next slide, Dr. Jackie. It seems to keep going back. Yeah, okay. So CBD has anti-cancer activity in different types of malignant tumors. And more interesting, this cannabinoid has influence on tumor progression. Significantly important is data for its synergistic anti-cancer activity with other cytostatic drugs, its tumor sensitizing or protective effects, which create a possibility for application of CBD as a component of combination schedule of chemotherapy or as adjunctive drug. In light of its safety record, they considered that CBD is and considering that CBD is currently used in clinical practice, the findings in this paper summarized suggest that CBD might be worthy of clinical consideration for cancer therapy. So it was proposed in a different paper that cannabinoid effectiveness is directed against the changes in the tumor cells received in the different stages of cancerogenesis, reducing the expression of the 1D1 gene and some other signal molecules that are overexpressed in aggressive forms of cancer. So remember, we talked about the CB2 receptors and how these are upregulated in the tumor cells, and they actually regulate cell division. So just based on that, which has been found to be true, there is a possibility that the CBD would help in terms of manipulating that CB2 receptor, would in turn obviously manipulate the cell division within the tumor. And CBD, we know, does act on CB2 receptors primarily. And this is the idea behind a lot of the clinical trials that we have been seeing, where people have been testing CBD at various concentrations on patients with cancer and in different tumor cells. And so far, there aren't any studies. There is no registered CBD medicine to treat cancer. There has not been a clinical trial that has concluded. However, some are ongoing for different forms of cancer. However, it has been found that just apart from the cancer itself, the CBD is very helpful with a lot of the symptoms associated with cancer, such as pain, which is a big one, where CBD has been found. A lot of patients have reported in the clinical setting that they have found a lot of relief in terms of pain, and it does also help them to sleep as well. And that is something that is there. But in terms of actually treating the cancer, this is still under study, and there is no proven medicine or registered drug to treat cancer. However, the science does show that this is very possible. In African traditional medicine, when you speak to some of the traditional healers, they talk about how they've been using cannabis for centuries, and the major indication that they have been using it is with cancer patients. They report that they're using it to treat. However, because this hasn't been looked at scientifically, and it needs to be studied what exactly is going on, and is there suppression of the cancer cells, and to what degree, and et cetera, et cetera. So there's still a lot of work to be done in terms of science. However, as adjuvant therapy, what we do know for sure, which science has shown, and there are publications to this effect, is the issue of the synergistic anti-cancer activity of CBD with other cytostatic drugs. So it sensitizes the tumor to other drugs. So it makes the chemo drugs actually more effective, which is really good for something that is also helping with pain and is also helping with sleep and the other symptoms like nausea for patients. And then it's also helping to make the chemo more effective. So the case for including a CBD-based drug within therapy for cancer in patients, I think the case there is very strong. And just in our experience here, since we have launched our cannabis-based medicine, which is registered as a complementary medicine as adjuvant treatment for pain and anxiety and other things. For the patients that and the doctors that have been using this medicine with cancer patients, they have reported that patients say that they sleep better. The pain, particularly with the pain, they get quite significant relief, which they don't get from a lot of the other drugs, as well as the nausea as well. So this is quite significant, and I think this medicine is really worth looking at, including it in in chemotherapy as adjuvant treatment for now. And as clinical trials are done and we get more scientific evidence, maybe then we can see what else it's actually doing. So just on the next slide, CBD use in breast cancer. So this is another publication. I have put the link there for further reading for those who are interested. So in the last decades, cannabinoids have appeared as promising therapeutic agents in breast cancer. Cannabidiol CBD, which is the main non-psychoactive phytocannabinoid, is one of the most promising. CBD inhibits the growth of breast tumors and decreases the migration, invasion, and metastasis of mammary cancer cells. It has shown to be active in hormone-positive, overexpressing cancer types, HER2, and the TNBC tumors. Interestingly, this cannabinoid potentiates the effect of conventional anti-neoplastics, such as your paclitaxel, your doxorubicin, your vinorelbin. This allows the reduction of their doses, and consequently, their adverse effects can also decrease. So this is very significant, because what this study is showing is, firstly, what we talked about, the potentiating effect of CBD when used with other chemo drugs. So it actually makes, it sensitizes the tumor to the chemotherapy. And this is important because they're reporting that doses can actually be reduced as a result. And you know that if you can reduce a dose of a chemo drug, you can actually help to reduce the adverse effects. And for most patients, I think anyone in clinical practice will testify to the fact that one of the biggest problems with chemo is the side effects. And it's usually the limiting factor in terms of how far we can go in fighting cancer. And so I think, so just based on this paper as well, where they are talking about how the CBD has that potentiating effect, I think that fact alone is actually very, very significant, and one to consider if one is considering adding a CBD based medicine to chemo as adjuvant treatment. I think there is a very strong case for this, just based on the publications that are there, and these are peer reviewed journals where they're saying this. And obviously, there's also the effect where they're saying CBD inhibits the growth of breast tumors and decreases the migration, invasion, and metastasis of mammary cancer cells. So obviously, I said there are still clinical trials. There is no registered medicine. So this cannot be said definitively in terms of a particular medicine, but the science is there. These are published journals where they are talking about this inhibition of tumors. And we do know that because of the CB2 receptor, which is expressed and controls the cell division in tumors, and the fact that CBD acts on CB2 receptors, the science does follow. And hopefully the clinical trials will catch up. So the other thing that they mentioned in this particular paper is how CBD is also able to palliate some of the major adverse effects associated with anti-neoplastics. For example, your peripheral neuropathy and your cardiotoxicity, but also some of the common issues, adverse effects of chemo we talked about, such as the nausea, the pain associated as well with cancer, plus with the chemo as well. And CBD is very helpful in terms of working with this. And moreover, the effect it has as an anxiolytic, that plays a significant role for patients in terms of adhering to their chemotherapy. And I think it's really worth considering to include a CBD-based medicine in chemo for patients, just based on what has been published, the information that is there in science, and also what we see in clinical practice. So just on to the next slide. What I've done for the next two slides, I've just included more publications, further delving into some of the things we've talked about in terms of the use of CBD in cancer and what is the case, what does the science say. So what I've done here, I've attached the links for those who want to do further reading. But maybe let's move on to the next slide, and the one after that one. So these are for further reading. Okay, so these are studies, cannabidiol use in cancer management in the US, because I got to thinking, okay, so what is happening in other countries? Who's using? How much are they using? What are they using it for? And what are the patients saying? And so this is another publication. I've put the link there for those who want to do further reading. But basically, this is a cross-sectional survey in 926 patients at the Fred Hutchinson Cancer Research Center. This is in Seattle. And what they found was that 66% of their patients had actually used cannabis previously. 24% of them had used it in the past year. And of that 24% who'd used it in the past year, which was about 222 patients, who were actually active users. So they were actively using cannabis, and these are cancer patients who are actively using it. 75%, a whopping 75% of these patients had used it for physical symptoms, such as pain, nausea, and appetite. And this is what they reported to have been using it for. 63% of them used it for neuropsychiatric symptoms, so just stress, coping with the illness, depression, mood improvement, sleep. 26% reported that they believed the cannabis was helping to treat their cancer. So this is the patient. This is what the patient believed. Obviously, like I mentioned, there is no registered drug. There's no clinical trial that's been concluded yet in terms of treatment of cancer using CBD. However, there are some that are ongoing, quite a few. But regardless of symptom, approximately 51% of patients judged the cannabis to be of major benefit, and 39% found it to be of moderate benefit. So basically, that's 90% of all the patients that had been using this cannabis found it to be of benefit, major or moderate benefit. This is actually really significant, because if you look at many of the studies that are done, you don't usually get 90% of patients saying the drug is of benefit, and particularly that 51% where they've said it's of major benefit speaks to how these patients found it to be quite useful. So on the next slide, this is another survey which was also done in the US. It was an online survey of 612 US-based members of the breastcancer.org and healthline.com communities. These people had a self-reported diagnosis of breast cancer within 5 years. And this study found that 42% had used cannabis for relief of symptoms, 78% for pain, 70% for insomnia, 57% anxiety, 51% for stress, and 46% for nausea and vomiting. 46% of these patients actually believed that the cannabis was treating their cancer. So these are the patients who were responding, the respondents. This is what they believed. Of those who were using the cannabis, 79% had used it during treatment. They used it while they were having their chemo or their radiation or surgery, whatever treatment they had. So basically, they used it as adjunct treatment, along with their other therapy. But this is actually significant because this is a different study with 612 participants, and quite a significant number found it to be helpful, particularly in terms of relieving the symptoms associated with their chemo or the cancer itself. So that was pretty significant. So on to the next slide. I'm just going to speak briefly on the anticonvulsant properties of CBD. We all know that there is the registered medicine, which is CBD based, Epidiolex, and it is used as an anticonvulsant, and it is registered with the FDA, the European Medicines Association. I'm not sure here in Southern Africa if any of the countries have yet registered it. I know in Zimbabwe we haven't registered it yet. But basically, the science behind this, the mechanism of action, how is CBD acting as an anticonvulsant? So this has to do with the GPR55 receptor. This is strongly expressed in the nervous and immune systems, as well as other tissues. It is a G protein coupled receptor. So activation of this receptor, the GPR55, increases the intracellular level of calcium ions. So it increases the cations, the calcium cations. So CBD is a GPR55 antagonist and can modulate neuronal calcium levels depending on the excitability of cells. So CBD antagonism is manifested as an anticonvulsant effect. So basically, we're saying that the CBD is acting on the GPR55 as an antagonist. The GPR55 receptor is responsible for modulation of neuronal calcium levels. So if we know how other anticonvulsants work, we're quite aware that they mainly, their mechanism of action is mainly by modulating calcium, intracellular calcium, and this modulates the excitability of cells. So this is very similar to how other anti-epileptics work, your carbamazepines and your sodium valproates. So this is basically the mechanism of action that is thought to be in effect, where CBD has been registered, particularly in the case of Epidiolex, in terms of its anticonvulsant property as for seizure control. Okay, next slide. In neurodegenerative disorders, so allosteric modulators of CB1 receptors have the potential to treat CNS and peripheral disorders while avoiding the adverse effects associated with orthostatic agonism or antagonism of these receptors. There are published clinical reports of CBD easing symptoms of Parkinson's, Alzheimer's, etc. So this is thought to be how it's actually working. Sativate, which is registered for treatment of spasticity in multiple sclerosis. So there is a registered medicine which did go undergo clinical trial, and the evidence was shown, and it is used to treat the spasticity associated with multiple sclerosis. Okay, so on the next slide, I just included this particular slide just to show, when we talk about the different cannabinoids, because some people obviously are just, wondering, so how come this thing is doing so many things, so many indications for just the one plant, right? But like I mentioned earlier, we're talking about 100 different cannabinoids. We are talking about over 500 other compounds which have some medicinal effect within that same plant. And this is mainly the reason why we see so many things happening. And so there are derivatives of CBD, just as an example. And each derivative of CBD actually has a different effect in terms of what it's doing in the body. So this is pretty significant because then there are some derivatives which would exhibit some indications more than others. So this is where it becomes quite significant. So I included this diagram just to show, the different levels of activity in terms of agonist activation or antagonist activation for each derivative. And this just speaks to some of the differences that we see for cannabis. I didn't talk about the anxiolytic effects of CBD. I don't think. However, as you can see, that CBG, sorry, back to the diagram, the CBG is actually quite active on your serotonin serotonin receptors. And this is pretty significant because it speaks to some of the things that we see. Okay, so on the next slide, just basically to talk about some of the registered medicines. Is it registered? Yes, it is, in many different parts of the world, for different indications. Some CBD-based medicines have already gone through the double-blind randomized clinical trials, and the products have been registered. Some products are registered as complementary medicines for adjuvant treatment. There are ongoing clinical trials. So this is one of the ones that is registered is Sativex. I spoke about this earlier. It is an oral spray, and it is indicated as treatment for symptom improvement in patients with moderate to severe spasticity due to multiple sclerosis. So that's a medicine that's registered. We have Epidiolex. We spoke about this before. It is an anticonvulsant, which is also registered. On the next slide. So Epidiolex contains 100 milligrams of CBD per ml. The recommended starting dose is 2.5 milligrams per kilo, and it's taken twice daily for 1 week. After 1 week, the dose should be increased to a maintenance dose of 5 milligrams per kilo twice daily. Epidiolex is indicated for use as adjuvant therapy of seizures associated with Lennox-Gastaut syndrome or Dravet syndrome for patients 2 years of age and older. Symptoms of these conditions include multiple types of seizures, fits, abnormal electrical activity in the brain, learning disability, and behavioral problems. So that's another one that's quite popular. I think it was the first registered Epidiolex. And then, obviously, on the next slide, the Australian Medicines Authority has been very good in terms of registering cannabis drugs. I think they've been in the forefront in terms of cannabis-based medicine. They've done really well, and they actually have a list of CBD or THC-based medicines which are available for prescription. Some of them are under clinical trial, some have not yet gone through clinical trial. And these range in schedule from Schedule 4 through Schedule 8. So basically, the scheduling has to do with concentration of THC mainly, but THC with CBD as well. And these are all available for prescription to patients. On the next slide, I'm just showing the drug interactions with cannabinoids. As you can see, these are the drug interactions that have been recorded. And, we said that CBD is a phytochrome P450 inhibitor. So you would see interactions there. And so this is just a summary. I think those who get the slides and are interested can actually go through these this information as well, just to understand it better. Obviously, there's a lot more science and recording happening as there is more use of CBD in medicine. We will be getting more information, and obviously we'll get more publications, which is very good and it's important. It's the course that any drug takes. And on the next slide, we have the Cannabinoida suppositories. And these are the registered suppositories in Zimbabwe from Sapps Pharmaceuticals. So Sapps Cannabinoida suppositories are a CBD-based medicine, and they contain less than 1% of THC. So they don't have psychoactive or addictive potential. They're registered as a complementary medicine recommended as adjuvant treatment. Cannabidiol, each suppository contains 50 milligram per dose. And these are obviously suppositories, so they're in rectal dosage form. Indications are obviously like for all other CBD product, just like any other. So on the next slide, I've just included advantages of rectal dosage forms, because we usually get a lot of people asking, so why suppositories? Why not do, a tablet or something? But actually, the best way, and if you ask any of the guys in rehab or who are on the street, they'll tell you, because they know this more than anybody else, the best way to take cannabis is by inhalation. So it's absorbed well through the lungs. The very best way to absorb it into the body is by inhalation. The second best way to get cannabis into the body is rectally. When cannabis is taken, CBD is taken, it has a higher bioavailability rectally. And it's actually been found that oral CBD is only 53% bioavailable compared to the rectal form. And this is obviously due to the first pass effect, which is metabolism by the liver when medicines are taken orally. There's also thought to be a local effect when CBD is taken rectally. This is due to the presence of endocannabinoid receptors in the rectum. So we have your CB2 receptors mainly and some CB1 in the rectum. So there's a local effect as well. And this is quite significant in terms of why we've gone the suppository route in terms of CBD. And ladies and gentlemen, okay, I think the last slide is just clinical findings. So patients have reported that they've found it to be helpful as an antiemetic. They get better sleep. The pain is controlled. And there have been some reports of seizure control with some patients as well. So this is quite significant. And my last slide, I've just included this. This is leaps in medical practice. Because in 1940, penicillin mold juice, 2,000 liters of penicillin mold juice was used to treat a single case of sepsis. So we all know the story of Alexander Fleming and how penicillin was discovered, and it was just a mold. And all this guy knew was that this mold was very good at killing bacteria. And initially, no one had necessarily done a tablet or a capsule for this mold. However, they did know that because this mold works, they would grow the mold and they would formulate or mix up a juice, and they would give 2,000 liters to a patient to treat sepsis. And so why is this important? Because I think particularly with cannabis, there's been a lot of questions about, we don't know enough, the science is not, there's not enough information. So we know the 2 receptors. Are there any other ones? What are the other 500 cannabinoids, etc.? I mean, science is doing a lot of catch up, but this is something that has been used for centuries. The indications have been consistent from as far back as 4000 BC. And like Alexander Fleming, maybe what we have is mold juice right now, and maybe we have a little bit more. I mean, we do have some randomized double clinical trials that have been done, and a lot more science right now. But what we do know is that we're seeing a lot of patients reporting that they are getting treatment, and that is a positive thing. So, ladies and gentlemen, thank you for your time. This brings me to the end of my presentation. Jackie, over to you.
Sorry, I had to unmute. Thank you very, very much, Kudzai. That was a fascinating conversation. I haven't gone into the chat because I was worried it was going to come up on the screen. I know that Audrey had her hand up. Audrey, was that an accidental hand or an intentional hand? If it was an intentional hand, can you unmute your mic? I think it was an accidental hand. So, or she's still trying to work out how to unmute the mic. So, I'm going into the chat now. Sorry. Hang on, there's Audrey's. Audrey's come up now. Audrey, can you unmute your mic?
Sorry, Jackie. Thank you so much, Kudzai. I always enjoy this lecture. It was an unintentional hand up, but I really enjoyed it.
Thank you, Audrey. You're welcome, and thank you for attending.
I'd like to ask a question to you, Kudzai. I mean, it's quite clear that patients are using this anyway. you'll get it as the GP, they'll say, well, the oncologist isn't sure about it, but I'm using it anyway. What do you think is going to be the uptake? Do you think that there is a market for integrative oncology?
Hi, Jackie. So, yeah, I think what you say is true. I think in the case of cannabis, we've had the patients sort of moving a lot faster than the health practitioners, and they're way ahead. They will go and they'll buy it, because ultimately, I think that if you are a cancer patient and you are in pain and failing to sleep, and you need something to help you, you are going to find it, whatever it is. And the science will follow you because you will know what you know in terms of what you're feeling. So when patients report that I use this oil or I use this suppository and it actually helps me sleep and it makes the pain go away. As a healthcare practitioner, one may not fully understand the endocannabinoid system. They may not fully understand the mechanism of action, but the fact is, this mold juice is curing sepsis, and the patient has gone out and got it and they're using it and it's working. And I think that science will do a lot of catching up. But I think the most important thing that we should remember is this is not a new molecule. This is a molecule, this is one of the oldest drugs ever. In the world. We have records as far as 4000 BC. The pharaohs used CBD for treatment of various ailments. Um, whatever happened in between that caused the whole world to have a collective amnesia in terms of what this medicine is doing, is one thing. But the fact of the matter is, this is something that it's not a fad that has come with the millennials. It's something that has been used for millennia, for many many years, and patients since then have reported finding it useful. And the records are there, the historical records are there. The physicians who were treating the pharaohs in Egypt, in China, the physicians there, they were clear that this is a medicine they were using and the treatment was working. But more than that, I think particularly in cancer, at the end of the day, when you have 90% of patients reporting that this medicine has helped them treat their pain, as a healthcare practitioner, can you deny that? Can you tell a patient that no, your pain was not treated by this molecule when it was? And sometimes, because this is the endocannabinoid system hasn't really been taught in schools, and it comes with so much skepticism because we're so used to the addictive potential of THC and the psychoactive activity of that THC, and all of that. I think we really need to go back to be willing to learn, and sometimes to even learn from our patients as healthcare practitioners, and to ask them, so when you use it, what happens? How do you feel? And just based on that, they are getting treatment and it is helping. Particularly, we've had excellent responses from cancer patients in particular, particularly in terms of just treating the physical symptoms associated with the cancer and with their chemotherapy. But the science is also there. So this is not devoid of science. We went through publications which did talk about, the anti-tumor effects that have been shown and proven. These are publications in very recognized, reputable journals. And so what's there to argue? Particularly, especially I think when we talk about cancer, and especially when we talk about adjuvant treatment, I think that the case is clear.
I would agree with you wholeheartedly. Now, in the chat, there's just so many compliments. I don't know if you can scroll through it and see them. An extremely insightful presentation. Many thanks. Very informative. Thank you. Just lots and lots of thank yous. So I'd like to thank you as well. I'm in the middle of preparing a presentation on Artemisia. And again, it's a fascinating We use it in coartem all the time. But when you go back into how long it's been used for and for what, because it's not just used for malaria, it's used for trypanosomiasis and schistosomiasis and many other uses as well. And it was probably used during COVID as a tea and as an inhaling agent. So I think it's time that we started looking at the ancient remedies, analyzing why they work, getting them registered, and getting them in as adjuvant therapy. Because I would say the main thing between complementary medicine and allopathic medicine is complementary medicine is safe. So the important thing is to show the efficacy, whereas in allopathic medicine, it's important to show the safety. And so if we are using these safe and ancient products, what harm, what's the worst thing that's going to happen to the patient other than alleviation of symptoms, which is the job of a healthcare worker? So with that, we've run a bit over time. Thank you so much. It was a brilliant, brilliant presentation. At one stage, you had 260 people on the call. So
Hello?
with a bit of luck,
Hello?
we'll have some more people using that. I've got somebody with their hand up. Frida. Frida, you've got your hand up. Can you unmute your mic?
Hello?
I can hear you.
Okay, I couldn't have my hand up. I'm failing to raise it up, but can I go through with the question that I have?
Sure, 100%. The whole
Okay,
idea of
so
this is to be as interactive as we can.
okay, so I'm Victor Piri from Zambia, clinical pharmacist working at Cancer Disease Hospital and a survivor of multiple myeloma, currently in remission. Thank you very much for this presentation. I think I joined when it has already started, but I've benefited a lot. But my request is, how do I get access to the PowerPoint?
What we'll do at the end of this, I will give it to the tech team to put the PowerPoint onto the SADC group, if you're on the SADC group. If not,
I'm not.
You're not on the SADC group.
No, I'm not.
So,
I think I really need it.
Okay. So what I'd like you to do is, let me just see. I'm going to put the tech team onto this because technology and me are not the best combination. But if Pride, can you find, because I can only see you as iPhone.
Oh, okay. Victor Piri, let me rename, I think.
Okay.
I've also put our number on the chat. Maybe you can just send us a message, then we'll add him to the group.
Sorry, what was that, Pride?
I've put our WhatsApp number on the chat. Or you can just send us a message, then we'll add him into the group.
Okay, so if you send us a message, we'll add you to the group. Then in the morning, we'll share the presentation on the group with the YouTube recording as well.
Where do I send it? Where do I send the message?
On the chat.
I sent one already.
Which one was it? Because we can only see you as iPhone.
Thanks.
Hang on.
Which one?
I've got you down as iPhone 2.
Yeah, just